When the literature reports a late diagnosis rate of DDH as 3%, why do we have a misdiagnosis rate of 44% in southwestern Ontario? To answer this question, we must understand what developmental dysplasia of the hip really is. DDH is a condition that affects 1 to 3% of all newborns. It is linked with long-term complications such as chronic pain, arthritis, and gait abnormalities. DDH is the malformation of the ball and socket joint of the hip. We hypothesized that community centers who are less exposed to populations requiring subspecialist pediatric care are more likely to have an increased incidence of misdiagnoses. To test this hypothesis, we performed a retrospective chart review on 114 patients diagnosed and treated for DDH at London Health Sciences Centre in London, Ontario. We used chi-square analysis to test for any associations between 4 groups. These groups were patients with an early diagnosis made within the first 3 months of life, a late diagnosis made after the first 3 months of life, and those patients referred from a community center or an urban center. In this case, our urban center was London, Ontario, and all other centers were considered to be community centers. Our data showed no association between those patients referred from a community center and those patients receiving a late diagnosis of DDH. This did not support our initial hypothesis. We did, however, find on secondary analysis an association between those patients receiving a late diagnosis of DDH and those patients with no known risk factors for DDH. What kind of information can we draw from these results? Firstly, we can tell that the late diagnosis of DDH is not location dependent and affects all of southwestern Ontario equally. Secondly, we can determine that there is some baseline understanding of what developmental dysplasia of the hip is and its associated risk factors. Current Canadian guidelines dictate that all newborns should be screened for DDH at every primary care visit until they are able to walk. These guidelines are based on an initial Cochrane review, which showed that imaging studies were not necessary for appropriate screening. This study, however, used skilled examiners in their report. We can therefore assume that there is one of 2 reasons why we have such a high incidence of DDH in southwestern Ontario. 1. Our primary care practitioners are not adequately trained in the diagnosis of DDH. Or 2. They're not following appropriate screening guidelines at every visit. More likely, however, it is a combination of both of these factors that are leading to our higher incidence. We believe that the next step in our study should be a formal survey of primary care physicians, assessing both their comfort level in diagnosing DDH as well as their current screening practices that they use within their own offices. Lastly, we believe that a cost-benefit analysis of introducing routine ultrasound in all newborns may pave the way for future changes in screening guidelines in Canada. Thank you.